Hi everyone, good afternoon and welcome to the second panel of a packed day. Reconciling the goals of public health and public safety. Like Eleanor said, my name is Millie Shepard. I'm a licensed clinical social worker with 10 years experience within healthcare, and I'm currently the program manager for a violence intervention program at MedStar Washington Hospital Center in DC. I'm so excited to introduce and facilitate this conversation with a robust panel today. In this panel, we'll explore law enforcement perspectives on the potential for person and public health-centered approaches when law enforcement and healthcare intersect. Please utilize the question and answer function on the right side of the screen and submit any questions. We might not be able to get to all of them. We've had a lot of really good ones today, but I'll do my best. For the sake of time, I implore you to read the full bios of everyone on this panel on the symposium website, but without further ado, I will introduce Rosa Brooks, who is a law professor, journalist, author, and commentator on foreign policy, U.S. politics, and criminal justice. She founded the program on innovative policing at Georgetown University Law Center with the mission to identify and advance new approaches to long-standing challenges in policing. We have Dr. Thomas Duncan, who is a trauma medical director at Ventura County Medical Center, where he is an assistant clinical professor of surgery. He founded the violence intervention program at Ventura County and is an active board member for the Health Alliance for Violence Intervention. Dr. Tracy Kesey is the Senior VP of Justice Initiatives and co-founder of the Center of Policing and Equity. She's a retired 23-year veteran of the Denver Police and a graduate of the 203rd session of the FBI National Academy at Quantico. Charles Dempsey is a retired detective with the Los Angeles Police with 34 years experience. He's retired officer in charge of the Department's of Mental Evaluation Unit, and prior to his career in law enforcement, he worked as a charge nurse in a psychiatric unit. Like I said, I am so excited to have the opportunity to initiate this conversation, and as we saw in some of the question and answers of the last panels, people are really eager to hear your perspectives. I'm going to start by asking this question to Detective Dempsey and Dr. Kesey. What is your understanding of the goals of law enforcement when entering a clinical setting, and how is the job of law enforcement different in a healthcare setting as it might be versus other settings that they enter on a regular basis? So Detective Dempsey, if you want to start.
I think some of the challenges that we deal with is understanding who the patient is. Is the patient a suspect, a victim, simply a witness? And all of those really kind of dictate the way a law enforcement officer should approach that particular individual in the healthcare setting. And sometimes that can be very complicated, and it creates sometimes an adversarial relationship, not only with the person who's being treated, but sometimes with the hospital staff. So I think framing who we're dealing with and the why we need to speak with them and how we're going about it is extremely important.
Great, Dr. Kesey.
Yeah, and I agree with Charles on that. And the other piece that I would bring would be around safety. We heard this in the earlier panels, so it's not just, what do you need there, but we often find that the interaction or the reason for their presence is really based on safety, right? So we're here to make sure that someone is safe. The question becomes who is safe and who are we really referring to? So I think I absolutely agree with what Charles is saying, and I would just add that piece to that as well.
Right, and in our previous conversations, Dr. Kesey, you brought that point up, which I think is so important, of who's making those decisions on who is safe and how are they coming to that conclusion. Do we defer to law enforcement on that? It seems as though in a lot of situations we have to. Is that the only option? Is there a way to have that decision of who is safe and how to kind of create that safety, a more collaborative process?
Absolutely, and I think it's more than that, right? So, we also have to talk about employee safety, because I think one of the things I was listening to in regards to the toolkit was the question of who are we really trying to protect here? Because oftentimes, even with new policies and new narratives, your own employees may not agree for their own safety. They may say, we want officers here, whether it's not certainly not a public space, but for our safety, we believe they should be. And so that is going to be probably one of the bigger challenges when you're talking about collaborating and making these changes, is that you have staff themselves who do not believe that they are safe, and how are they defining that safety. So I think you're absolutely right, Millie. It's important not just who gets to define those things, but you have to also bring in other parties that you may not think about, and staff is one of them. We've always had, and even as retired law enforcement, we've always had a familiar relationship with nurses and clinicians and doctors in those spaces, which historically have allowed us to get what we've needed. And so, we're really talking about changing that particular relationship, and you're going to have some folks that are not going to be in agreement with it. And that is something that you're going to have to really be aware of.
Right, absolutely. And Thomas, I think when we spoke, you actually gave an example of sort of this idea of employee safety and taking their concerns into consideration when managing the care of patients. Do you mind sharing that example with us again today?
Sure, and thank you for having me in the panel. Yeah, generally when you have a situation in which there's an active shooter, you have an active shooter in a hospital, you have a situation in which there's an abduction, or a newborn is abducted, or a child is abducted, then obviously you want the law enforcement agents to be available to protect you. And when you have situations in which there are patients that are psychotic through no means of theirs, they're psychotic or they're on drugs or alcohol, and they're violent to the staff, then you need some help in terms of controlling that situation, because you don't necessarily want it to get out of hand. Because if it does, then you have individuals that are injured, both staff and the patients themselves, and it's not a win-win situation at all. So you need that help from law enforcement every once in a while, and at the same time, there needs to be boundaries, and that fine line needs to be defined.
Right, absolutely.
And Millie, if I might jump in,
yes,
just
please.
real quick, and I agree
Absolutely.
with Dr. Kesey and Dr. Duncan, is hospital staff, having worked as an emergency room nurse, assault is real. It does happen. And I agree with the other two panelists. The safety of the staff in the hospital sometimes is overlooked. That's just part of your job, and from hospital administration. But the reality is it isn't. And if we can have security officers or police officers provide some sort of barrier for the staff so they can do their job if we have a patient who's violent, I think it's extremely important. Extremely important, and it needs to be discussed.
Right. I think you're absolutely right, and I don't think anyone would disagree that the sort of threat to staff is and can be very real. I think that one question that gets brought up a lot in these conversations, though, is it the best role for law enforcement, public safety, or hospital security to take on that role? And we kind of talked about this a lot, about the burden that society as a whole has put on law enforcement to have to call and respond to a variety of different situations that they might not necessarily be the most prepared for or have an expertise in. Rosa, if you can kind of talk to that education piece and how important it is to educate law enforcement, but also violence prevention workers and hospital workers on kind of what the role is in that moment.
Yeah, thanks, Millie. I think the difficulty, as my colleagues on the panel have already said, is that the role of a police officer in a hospital setting depends. There are times when officers are there because there's just been a shooting. They've accompanied the shooting victim to the hospital because they're worried that whoever shot them is going to try again, and they're actually protecting that person. Other times they're there to protect the staff. Other times they are trying to get some information in inappropriate ways. And because these are often situations where, at least initially, they're moving pretty quickly, it's very different when it's day 3 and someone's been in the hospital for 3 days and everybody's had plenty of time to argue and talk it over and so forth. But in a situation where there is an emergency, it may be next to impossible to sort that out really quickly. But I guess the one piece of that I would emphasize, having watched the presentation about the toolkit, is on the one hand, it's absolutely correct that medical personnel should not automatically assume that police get to do whatever they want just because they are wearing uniforms or they show you a badge. They should not automatically assume that they have to say yes. But equally, they shouldn't automatically assume that the police are the enemy of the patient. Sometimes the police are there quite literally to protect the patient and or protect the staff. So it's hard to know the difference. And I think that's part of the education that needs to take place, both for officers and for healthcare personnel. For officers, often they, particularly at the patrol level, often don't get much guidance about what they're supposed to do. They're told, well, you have to go to the hospital. You have to accompany this shooting victim or stabbing victim to the hospital, or you have a prisoner who's just said, I feel really, really sick. I think I need to go to the emergency room. You have to go with them. And they don't get much instruction about what they're supposed to do. And so they do what cops do by default, which is they kind of stand around going, oh, well, I guess I've got to stand here. And they often, certainly in my own experience, don't have in their training any differentiation between, okay, if you're coming in with an active shooter and there's somebody else outside, maybe you behave a little bit differently than if you have someone who shoplifted, $50 worth of stuff and has a headache. That there's a level of vigilance and a level of intrusiveness that might be appropriate in one that would not be appropriate in the other. So I think there's a lot of education that's needed for officers to try to have a more nuanced understanding of what their role would be in different situations, but similarly on the side of healthcare workers, to have that understanding that sometimes it's an emergency and don't automatically assume that the police are wrong any more than you should automatically assume that they're right.
Right. And in conversations that we've had specifically in my role in working with Dr. Hall and meeting with the Metropolitan Police Department specifically, they mentioned that same sort of like nervousness or uncertainty of what their role is when they come into a hospital. Feeling as though they don't have a lot of guidance and they're just kind of showing up because they're following the violent act that just happened. And so sort of how do we provide them more guidance or one of the strategies that we talk about from the healthcare perspective is to have a point person for them to check in with and talk to and go from there, so they're not kind of milling around and seen as in the way when that's not always there. Like that's not necessarily their intention, right? I think that both in healthcare and in police, we kind of the common thread is helpful. Like we want to be helpful, right? So I think that if anybody can kind of speak to that and how we can kind of, if there are some strategies in which healthcare can maybe assist in that education piece for the officers who are responding to these settings.
If I could, and I mean, I think it makes sense. And I just want to sort of go off of what Rosa was saying about who is showing up in those spaces, right? Typically it's patrol. And patrol is the group that is usually holding the scene or trying to figure out what we need to do. And I think a point person is absolutely appropriate, but I also think part of the questions for law enforcement is, and I believe it was in the toolkit, is why are you here? If you're here because you're guarding someone, I think that is the initial question someone needs to ask, why are you here? And we also need to make sure that part of, and typically what happens in patrol training is that they are given some minimal guidance, whether it's preserving evidence, whether it is protecting safety. So there is room and space in that training piece for medical personnel to say, okay, let's make sure we have agreement when you come into these spaces. What does it look like? Patrol is going to be different than having the investigative detective there, who is typically going to have a little bit more knowledge around when warrants are needed, who and when you can talk to people. And I think that is important. I think oftentimes we forget in the academy sort of low-level setting and when you get your actual life experience that there are learning moments that sort of happen in real time. But I think where you're talking about having a point person, I think that's important. But I also think it's important from a collaboration standpoint to sit with your law enforcement organizations and have a sort of working session over what are the rules when we come in, right? And making sure that everyone has a shared understanding and shared language around it. Not thinking that all of your contacts with law enforcement, if you are in a county, you may have multiple departments coming into your emergency room, and you can't assume that they all are going to have the same understanding and training around what needs to be done. And I think it's critical, though, to have those folks at the table for that shared understanding and sort of the shared rules. And when those things don't work, there also has to be a mechanism for making sure those things get corrected, whether you ask a supervisor to respond on scene or to be at the hospital, so you can begin to coordinate that work. So I would, Rosa said, just sort of hit home, don't lay all that on a patrol officer who's told very minimum, other than get in the ambulance and go with this person or go to the hospital and go there. There should be asking of supervisors, right? Where is your supervisor? Can we have a supervisor respond so you can begin to do, I think, a little bit more higher level coordination around why the presence is there and why the presence is necessary. So I just wanted to add in that particular piece.
Right. No, and I think that is a very valuable piece that honestly I hadn't even thought of, to just kind of go up the chains of like can I get more information? Because you're right, the person who's, the B cop isn't necessarily going to know the protocols and procedures or what the next steps would be. Can I
get your sergeant on the phone?
Right.
Can I get your sergeant on the phone? But it goes in the other direction too, that I think especially officers may not know who in the hospital has the authority to tell them something. Is it a nurse? Is it the doctor? Is it the head of the ER? If one random person comes up to them and says, "What are you doing here?" Do they have to listen to that person? So that lack of clarity, they don't want to get in trouble. They don't want to leave their post or what they imagine to be their post, sitting right in front of that emergency room bay or whatever it may be, and get in trouble just because someone says, "Oh, you can't be here," and then they'll get yelled at by their sergeant and, "Well, what were you doing leaving your post? I didn't tell you to do." So I think that uncertainty goes on both sides, but it can certainly be addressed in part by saying, medical personnel saying, "Can you get your sergeant on the phone?" and officers saying, "I'd like to speak to your supervisor so we can clarify this."
Right. And I think that even among my team, we've kind of made some jokes about like not wanting to make eye contact and be those friendly set of eyes for a police officer, because they're kind of looking for who they can go to and try to get some information that they need. And if they lock in with you, like it might be you, and I'm not the person, it's not my role. And so trying to kind of avoid those situations and but not guiding it per se. One of the questions we have from the audience, which is kind of along a little bit of what we were talking about, is if someone can please address what specific education and training law enforcement has to be able to quickly navigate those situations on the fly. And it sounds like there's going to be some difference between the patrol cops versus detectives, but Rosa, if you can speak to that, I know that's a lot of what you do is interacting with the training piece.
Just to clarify, was the question what training do they currently have, or what training should they have? Couldn't hear.
It says I would say we could maybe try to address both, but what they currently have.
So it's really hard to answer that question because, as you all probably know, we don't have a national police department in this country. We have more than 18,000 different law enforcement agencies around the country, and the training is often quite different for each of them. And so training can be really wonderful and comprehensive in one place, and 2 miles away in the neighboring jurisdiction, it can be awful. I can say a little bit, my own experience going through the police academy in Washington, D.C., was that it was really very minimal. We were told, you have to go if a prisoner, someone who's been arrested, wants to go to the hospital. Number one, the instruction is to err on the side of, you don't get to say, well, no, you don't, you look okay to me, even if the person says, I have a hangnail, or, my head hurts, I have a migraine. You have to take them to the hospital, and you have to stay with them until either they're released or you're relieved by another officer. If you have a violent crime and a victim is taken to the hospital, you have to go along, in part, again, to protect them. And that's about the extent of the instructions. In DC, patrol officers are instructed, do not even think about interrogating anybody. It's not your job. You're going to screw it up. It's the job of detectives. So, you can ask really basic questions like, what's your name? And you can ask things like, what happened in order to conduct the immediate investigation? Like, what happened? Did the guy who shot you run that way? Or, what color shirt was he wearing? But that beyond that kind of essential investigative questions, you are not permitted to interrogate someone. And that line, I think, for patrol officers is made pretty clear. And to the extent that they ask interrogation type questions, typically it's because they're screwing up and they forgot. And that's also something healthcare professionals can just remind them. This is a patient. Has this patient been Mirandized? Should you be asking those questions? Could you get your sergeant on the phone? So I do think that certainly in DC, the education was not really adequate. It may be better in other places. I'd be curious to hear my colleagues' perspectives from coming from other jurisdictions, whether they feel like it's better elsewhere.
It's not much better. So I don't know if we seek solace in that. It's not much better. But I also think that when we come down to a couple of environmental issues that are happening, right? So how fast are these things unfolding is always going to be key in regards to doing this. But the other question was around which types of training do they need? We often find officers have to have consistent training around the law, around Fourth Amendment rights, around understanding what it means to be in private place versus a public space. I think Rosa mentioned this, right? When does questioning become an interrogation? So it is all of those pieces, and it really does help if officers do scenarios much like the toolkit did, because what we really find is in the heat of the moment, folks are believing on the side of safety and justice, they're doing what needs to be done. They're collecting, someone's evidence, or they're collecting items that belong to people that they shouldn't really be collecting. But we also have to talk about that oftentimes in municipalities, there are two jurisdictional entities happening in those emergency rooms. There is a sheriff, typically, that is the person that is responsible for detention and detaining once an officer delivers somebody to that emergency room, and then the actual officer that is there. So you're really sort of dealing with two separate types of events that you really are going to have good understanding of and good training around. And I think that's the other part. And you also have to be, and I'm with Rosa, call a supervisor, because every moment is going to be different. It's not going to be the same, and you're going to want to make sure that you have a good understanding. And this is why when you develop the toolkits and those types of things, officers and law enforcement have to be at the table because they don't have that kind of awareness. I guarantee you that a lot of patrol officers believe there's some sort of policy that's governing their presence there, and a lot of times it is not. And so I think there's lots of spaces that need to be reviewed on a regular basis, especially those officers that have hospitals in their precincts. Oftentimes they have the best relationship, so they know how to do what they need to do. But when you have multiple jurisdictions arriving on active shooters, multiple victims, you are really going to have to make sure that those rules are trained at the academy in the roll call setting. So a lot of times the academy might not, may give you minimal, but the roll call setting where you get that information prior to leaving, prior to going out on patrol, having it somewhere on the, on the MDTs in the car. So if you do go to a call, there's multiple ways in which you can do that, where they can have it sort of as a cheat sheet so they can look and see, what am I supposed to do when I get here? But again, agreeing with Rosa, there is not much other than you need to preserve either a evidence in some sense, whether that's the individual or property pieces. And so often you'll find them sort of like, hanging about in emergency rooms, trying not to be in the way, but, really not sure about what they should be doing.
Yeah, I agree that there's got to be some sort of evidence-based toolkit or framework to utilize, and that document is being created by the hobby, and I know they're working on it in addition to other organizations, but it would be great to have that so that, like you said, the law enforcement agents can have a cheat sheet or a pocket guide that they can pull out and refer to in the event that some issues come up that they need to address. And I think it helps if the county, if for example, you go into the county, interact with law enforcement agents on a committee level. We have multiple committees in the county, and we have a multidisciplinary committee in which there's law enforcement together with other community-based organizations. And when you sit at a table with those law enforcement agents and you also share some activities with them, for example, we have helmet safety days, we have bike safety days, and we also do what's called Stop the Bleed to show the public how to prevent bleeding by using tourniquets, etc. When you have those scenarios, then you interact with law enforcement, and then having the ability to have law enforcement under what's called a family justice center model, in which you have multiple organizations under one roof. In that situation, you can hash out policies back and forth and also come to an agreement how to address patients when they come into the emergency department and how to interact with clinicians. Because if one of the officer steps out of line, and we know the chief of police, and we can make a direct phone call to the chief and say, one of you guys stepped out of line, and we need to address it before it gets to a situation that's uncontrollable. So once you have that level of interaction with the leader of the police department in your county, it goes a long way because they tend to listen to you and tend to address issues that come up in real time.
I'm glad that you brought up the Family Justice Center model. Can you speak a little bit more about those for individuals who aren't familiar with what it is and what the work that you guys have done with them?
So the Family Justice Center is a model that initially started in San Diego about 20 years ago by Gail Strack and Casey Gwynn, both attorneys. But the model is one in which it's like a quote unquote one-stop shop in which you have multiple services under one roof. So you have law enforcement, you have legal aid, forensic examination, psychological treatment for those that are afflicted by domestic violence, intimate partner violence, elder abuse, or even child abuse. So rather than having the victim go from one organization to the other trying to obtain services, it's all under one roof, and they have the ability to go to fruition with their care, as opposed to going from one address to another and giving up on the fact that they can't obtain the help that they need because they have to travel a long distance or from one organization to another. And in that scenario, when you have everything under one roof, then people are more apt to follow through and eventually get out of that realm in which they're being a victim and be empowered. They are empowered to now get out of it and do bigger and better things with their life.
So I'm going to shift a little bit now because we're getting a lot of really good questions from the audience, and I want to try to get as many of those in real time as possible. We've actually had several variations of similar questions regarding behavioral health responses. So one of them that just came up was, what do you think the role of behavioral response teams in place of law enforcement security, what do you think of when responding to incidences in clinical settings, even emergencies? Detective Dempsey, I don't know if you want to take that for us.
Sure. And I'm just going to roll back just real quick. Everything we're talking about in the previous group talked about, we need to memorialize that stuff because it can't be just practice. It does need to be policy, and we do need to educate everybody. And the working in an echo chamber, whether it be a law enforcement echo chamber or a public health echo chamber, that's not conducive. We need to collaborate on all this and have all players at the table. We just recently wrote a mental health guide for the state of California. So each state has their peace officer standards and training that accredit agencies. So if there's a thing, let's say we're dealing with people in a mental health crisis, we need to then advocate at the state level so it'll impact that academy training. So the officers will start getting some information that the advocacy groups and the individuals who are most impacted by their intersection with the criminal justice system have a voice at the training level. So I would advocate for these groups to go, if they're working in each state, work to the peace officer standards and trainings, and you can really make a difference on how officers in the academy are trained. In services department, right? That's a little bit different. I think both the non-law enforcement crisis teams and the law enforcement crisis teams have a place. In the city of Los Angeles, LA County has 48 different municipalities and the county sheriff participating in a co-responder model. But we also have non-law enforcement models who are responding to the lower threat crises. So each has its place. And actually, to me, the most important thing is understanding in the community developing a triage model. So when that 911 call comes in, that it can be diverted to a crisis center. it can be diverted to a non-law enforcement response and or a law enforcement response with a co-responder team if appropriate. But that takes a lot of work. These dispatch systems are pretty, they're not as uniform as they appear. We have fire dispatch, police dispatch. Sometimes they're combined, sometimes they're not. But each has a place, and it's important for us to educate not only the community, but also the clinical and the hospital staff on what your expectations are, right? And we have to understand that our expectations are not going to be always the same. But educating everybody that's in the mix will make us more risk sharing as opposed to risk averse. That's not my job, and walk away, or I'm not going to talk to you. I find that relationships as opposed to being confrontational is much more important. And we all know that I go into that admitting room, I go into that emergency room, and the admitting clerk is my friend, right? Because I've been there 1,000 times, and that same person's working there, and that's probably who I'm going to approach. But that's from experience. So I would encourage that we educate everybody on the capacity that is there and understanding our roles, and that they're not going to be the same. And there is a role for everybody. Just getting the right individuals to the right place at the right time is the real challenge.
Right. And sort of along that same line of education and really going back to this idea of who can feel safe and who's not feeling safe and how that is determined. Another kind of few questions we got. One in particular, the identify the identity of a hospital staff who feels safe with law enforcement around is important to consider. In general, our non-white colleagues do not feel as safe when officers are around. And so how important, and I mean, obviously it's incredibly important, but how are some ways to kind of take that into consideration when making these determinations? And oftentimes we do see that, young Black and brown folks who come in, particularly males with GSWs, are automatically deemed unsafe without any conversation. And sort of how can we switch that narrative a little bit?
Well, I mean, acknowledging the narrative. I mean, I think that's the biggest part of what our sort of hurdles have been around the space when you talk about race and law enforcement and how they interact. So it's not just, the staff of color that are going to be reacting and hopefully not re-traumatized by those interactions, but things like, having liaisons, making sure that there is a space where law enforcement can go into before they are put into public, into the emergency room. For example, in some spaces, they do have a officer holding room where you come in, the patient goes one way, the officers go another. And that way folks can be in there. There's tables in there, they can do the work. You have a liaison that can go in and ask, who are you here for? What's going on? And it's sort of, you want to make sure that you can minimize that contact, especially for those that are most, vulnerable and really do get triggered by seeing officers. And there has to be a recognition of that, because we find that a lot of times that's overlooked, especially for folks in their employment. That somehow you should be able to suck those things up and not be bothered by that, but that is not real life. And so I think the real acknowledgement of that and creating the spaces that are safe enough for the employees to continue to operate, and things like, making sure there's a space for officers to go right into. And there's somebody there who can go in and begin to sort of sort through what their needs are. And I want to go back a little bit, if I could, to what Charles was talking about, what types of models for mental health are important to work for law enforcement. And I agree with everything that you were saying. My one add would be, and what we're finding in the work that we do, is making sure that those models are meeting the needs of the specific communities that are most affected. Just because law enforcement would like to have some type of response that looks different, or it still has that element of law enforcement there, doesn't mean that's what the community wants nor needs. And we're finding that oftentimes is overlooked because we have examples of models that may be working elsewhere. We make the assumption those same models are going to be acceptable and work for what they need to in other communities, especially those that are most vulnerable. And so we do at CP, we always advocate the community's got to be centered in this. And that means you have to have a good understanding of the need. Oftentimes we don't see that. We see that public health, local, county, and city will take the edict from the state and just roll it down, and really not know whether or not it is truly what the communities at hand really need. And I think that is critically important, especially because we're talking about, and the reason why we're having this conversation today is because all of those aspects of law enforcement that are in social spaces are being re-examined, just like the hospital. But it does not sort of isolate the hospital from what really needs to happen in those interactions, especially involving communities of color that are most affected. And I think that is something we often forget. We want to do broader community when that's not really what we're talking about, nor are we trying to account for here. So I just wanted to lift that up, and I appreciate Charles sort of giving the different options and models, but it's equally important that those models match the needs, and those needs are coming directly from the community, not from groups of people who believe they understand better. And I think that's what we have been sort of trying to fight against, and that's part of this conversation here. How do you do that differently? So people do understand that the needs are being met and being protected in such a way.
Millie, can I jump in to say a little bit? You know what?
Yes.
She's 100% correct. We did a study, and we determined that the African American community in Los Angeles disproportionately utilized 911 in order to access mental health services. Does that statement bother anybody? It should, because what we've done is we've trained a community that when there's a crisis, dial 911. But the system that they're dialing into may not be able to appropriately direct them or create an appropriate response. So I agree 100%, Dr. Kesey. We need cultural competence and understanding what the communities need. We should tailor our responses around that.
Can I just jump in and go back to the question of, well, how do we educate people? With one suggestion, the training of law enforcement officers, that's a hard nut to crack because there are so many agencies, et cetera. But one thing that hospitals and other healthcare settings can do is create a flyer that is either literally posted on the door outside every emergency room bay or is handed out to an officer as soon as they walk in the door. And that piece of paper can say, here are the rules at our hospital. If for some reason you think that it's not appropriate for you to follow these because whatever, there's an emergency, this, that, and the other thing, here's who you should call, or you should tell the doctor who's responding, I need you to speak to my sergeant or something like that. I mean, part of what, as I said earlier, officers, the patrol level officers often feel really afraid of messing up. And the person they're afraid of is usually their sergeant. It's not the doctor. It's the person who's going to yell at them when they get back at the end of their shift. But if you can give them the ammunition they need to go, oh, it looks like the rule at this hospital is I'm not supposed to sit here. I'm supposed to go and wait over at this other place or something. That gives them the ammunition, poor choice of words, to get on the phone to their sergeant and say, hey, Sarge, the hospital's rules are this, should I do that? Is that okay? And then it sort of displaces it, and that conversation can happen at a different level. Because very often I do think that the problem is not so much that the officers are unwilling to abide by whatever rules the hospital sets. They just don't know that they have that option without themselves getting in trouble. And that, that piece of paper both educates them and gives them some cover if they need it with their department.
Right. I think you're absolutely right. And I think that, when we as clinicians and healthcare providers go into these conversations with each other, we often talk about law enforcement and their role in all this, but we fail to acknowledge our complicity in this as well as in healthcare institutions, and all of the things that we can do on our end to support our patients and their rights, but also provide this education and guidance for law enforcement so they're not kind of, as one of the comments says, hanging about, and that alone can cause harm, just the presence. And Dr. Kesey, like you said, sometimes just having a holding space for them to go to where they're not out and about and kind of heightening anxieties just by physically being present is huge. Absolutely.
Also takes the burden off any one individual to be the person to make that intervention. It means that you don't have to go and say, officer, I'm telling you need to do this. You're just handing them a piece of paper and saying, hey, look, here are our hospital guidelines for law enforcement in the emergency.
Right. Absolutely. This question is interesting to me because it's not something that I have experienced, but I'm really I'm interested to see sort of what your perspectives on it. It's preface with it may be Philly specific, so that might also not be why I'm familiar with it. But can you comment about the show-ups that are seen in the ED. They will bring in suspects to an ED for identification by victims and patients. Is this legal? Should it be practiced? What can a doctor do when they see this?
Yeah, I'm not
I don't
familiar
know.
with the show ups. Familiar with law enforcement bringing patients in when they need medical clearance before they go to jail, or they bring them in as a victim of a gunshot wound or a stabbing. But I'm not familiar with the show up per se. So that may be specific to Philly or that part of the country.
Yeah, I've asked to see if we can get any more clarification on it, because I do know that sometimes the police are used to identify patients who are come in as unknowns, but those are patients. So I'm not even sure myself if these are individuals who are seeking medical care in some capacity and they're using this, or
We do use that term in DC, and I'm not familiar enough with the specific rules concerning it. I'm hoping Charles might be. It may be a term that varies from place to place, but no, that's typically, it's the equivalent of the lineup of
There you go.
you were stabbed. You said it was a guy, who was really tall and was wearing a red shirt. Well, we caught a guy running away with a knife a block away who's tall and had a red shirt. We're trying to figure out, is this the guy? I do know that there are a lot of restrictions on whether and when show-ups can be done, but I'm hoping perhaps Charles has more information as a former detective.
Yeah,
so clarification, and that is what they're leaning towards, is these sort of lineups.
Right. So infield lineups, what they're called. So that's maybe a West Coast term, but so there are legal restrictions around. Generally, the victim has to be transported to the infield lineup. In other words, if you're going to identify somebody in the field, because technically, the minute you detention and asportation, which is fancy words, the person's in custody. So I've arrested him if I'm taking him to the hospital to show him to a victim. So I'm not going to question the practice. I will say, from my perspective, and having done those, that seems problematic, unless there's an exigency to it, and you'd really have to really articulate that exigency. So I'm not going to comment on Philly policy and procedure, but they're infield lineups, and what I would do is I would take a photograph and I would create what's called a 6-factor, and I would take that to the individual in the hospital. It's less intrusive, and it would create a less of a problematic environment for the healthcare staff and for the victim I'm speaking with. So, and those are very simple to do. So yeah, I'm not familiar with that. Not a practice we would do that I would infer anywhere in California, but it could be Pennsylvania, Philly specific.
Okay. I am just now looking at the time, and we have 1 minute left, so I have let some of it slip by me. But I wanted to just really thank you guys for your participation today, and it really seems like the biggest themes that I've picked up on are really the education piece, both for healthcare providers and law enforcement and public safety, but also this idea of memorializing. And we've been talking about this for so long, but let's really get to the work that needs to be done and memorialize all of these thoughts and forward and whatnot. So thank you.